Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, it is my honor and privilege to have with us here today Dr. Christine Moutier. She is the Chief Medical Officer for the American Foundation for Suicide Prevention. And today we are giving her the chance to answer some of your unanswered questions from our Synapse Half Day titled Before It's Too Late, Strategies for Suicide Prevention. Welcome, Dr. Moutier.
Thank you so much, Sabrina. I'm so excited to join you again and to hopefully reconnect with the folks who were there at that session and with other clinicians, because the topic of suicide prevention is obviously always important, but really top of mind these days with just everything that everyone is facing, including us in healthcare, but also for our patients and our patient care.
Yes, absolutely. So our first question, this person says, I have been told that there is little good, if any, evidence for any of the therapeutic interventions regarding suicide. Could you please comment on this and possible implications?
Yes, I would love to, because if we were having this conversation even, let's say, 10 or 12, certainly 15 years ago, that concern would have been true, because that's how recently the science has been growing with the number of high quality randomized controlled trials, particularly around certain psychotherapies for suicide, not just risk, but for rate reduction. And so what I'm talking about are cognitive behavioral therapy, which was then customized by Aaron Beck and Greg Brown with an AFSP funded grant actually to do that, to specifically hone in on suicide risk as the clinical target, in addition to the depression or the anxiety, the usual targets of CBT. CBT, also DBT, dialectical behavior therapy, is another one with a tremendous amount of evidence. And there are a couple of others that are also excellent, possibly a little bit harder to find, things like attachment-based family therapy and CAMS, Collaborative Assessment and Management of Suicidality, Dr. David Job's treatment. All of those have a robust set of data now to say that if you have a patient who is at risk for suicide and isn't engaging in any of those types of psychotherapy, that is something that you could actually consider and recommend. And I know it's sometimes hard to find those in a local environment, but with virtual therapy being more available these days, I would highly encourage that. And so what we're talking about, for example, with CBT, is that among high-risk population of patients, in one study published by Greg Brown and Aaron Beck in JAMA, and this was back in 2005, 120 adults seen in an emergency department after they had attempted suicide were randomized to either 10 sessions of CBT, again, specifically customized for suicidal people, so it's called -SP, versus enhanced treatment as usual, meaning just more supportive general therapy out there in the community. And then they were followed up 18 months later. And the ones who received CBT had 50% fewer suicide attempts. 50% of the patients fewer had any subsequent suicide attempts. And it's a similarly robust data set for DBT. And it's not just one study. Both of those, it's been replicated over and over again. And DBT, it's for a host of types of pathologies like people with borderline personality disorder, but also adolescents with reactivity, depression, anxiety, trauma. We can't say that anymore, that we don't have evidence-based treatments that have been shown to reduce suicide risk. Where I think it's a little bit trickier is around the medications, because there are very few RCTs that were designed specifically with suicide risk as the primary outcome measure. However, there have been a couple, and those give us reason to believe that there is either a body of evidence, even if it's not in the RCT type of methodology, that really supports medications to consider specific for suicide risk. And those are lithium. And that's for people not just with bipolar disorder, but with unipolar depression as well.
Right.
That's something that people sometimes forget. That suicide risk reduction has been shown for lithium, even just for depression, as well as clozapine, as well as antidepressants as a class. And those are more ecological and pharmacoepidemiological studies that show that for antidepressants. And then, of course, we have some newer medications that are coming online, ketamine and other newer agents that give us a lot of reason to hope that we're going to see results. I think right now it's a little too early to be able to say for sure that beyond the early period in terms of suicidal ideation being helped by ketamine, we do need more longer term studies. And in fact, we're funding a couple of those at AFSP.
Wow. The next question is, the Joint Commission requires use of validated screening on medical hospitalization. And this person says, I'm not aware of a well-validated tool for this setting. Do you know of any diagnostic tools coming down the pipeline? Is a full suicide assessment something like the Columbia Suicidality Scale? Is this appropriate for assessment for all children and adolescent populations in an inpatient setting? So I know that was quite a bit, but it was a pretty long question.
It's an important question because there are a number of tools, and I will just highlight ones, especially since this question is about patients who are undergoing medical hospitalization. There's a new tool, relatively new tool, called the ASQ, Ask Suicide Questions. And the Ask Suicide Screening Questions. Right. The ASQ was developed by Lisa Horowitz at the NIMH, and it has been validated both for pediatric as well as adult populations in medical as well as behavioral health settings. So it now is the screening tool that really does have the highest level of sensitivity and specificity for children over the age of 10 and adults. And again, in medical settings as well. And it's very short. It's a 4-item screening instrument that can be used as the start of screening and then assessing suicide risk. So I would point people to the NIMH website, where if you just search ASQ NIMH, you'll come up with their tools and actually with a pathway that helps health systems and providers know how to use it.
That's excellent. Thank you for sharing that with us. The next question is, how do you handle a patient who does not want to talk about their suicidal thoughts?
Okay, this is really a very important one because obviously there's a lot of stigma, there's a lot of fear that is still in patients' minds, even with their therapist or psychiatrist. And this clinician who's asking it obviously knows that, or maybe even has a particular patient in mind. And so there's a couple things I want to say. That there's actually some research. We at AFSP funded Dr. Ursula Whiteside, who looked specifically at, it might be something a little bit different than this person was asking, but it might apply. So there are obviously patients who have denied suicidal ideation at their last outpatient visit or when they were being discharged, from the hospital. And then after a short period of days or weeks, show up again having attempted. And so Dr. Whiteside's study did a deep dive with that cohort of subjects for whom that exact scenario applied. And it turns out that it breaks down to about thirds. So a third of the patients who denied suicidal thoughts, it turned out that they were not having suicidal thoughts at that time. And we know that suicidal crisis and suicidal risk is actually very dynamic. It changes over time. So that can be a very legitimate and real phenomenon, that they were being perfectly honest in that moment. And then things changed, and that perfect storm of those suicide risk factors reemerged and got them into a state of being suicidal again. Another third of the patients had denied suicidal ideation much more intentionally, and even while they were either ambivalent or actually having suicidal thoughts, because they were afraid of what would happen if they revealed that information. And specifically, obviously, we know patients can be very nervous about being held involuntarily. And then a third, this is really interesting, don't admit they're suicidal because they're actually feeling like a sense of protectiveness about their treatment provider, wanting to not even have to go there and not have to burden that other person with that information. It sounds maybe surprising to us as clinicians, but on the other hand, maybe not. And so I think back to the question itself, if the person that this question is about is related to a patient that you know is having suicidal thoughts, or that you're just more generally concerned about their suicide risk, then what I would do is, again, this depends on so many different factors, but I would probably ask a lot of open-ended questions, be very gentle, make sure that you're using their language, meet them where they're at, explain to them, make it clear what the limits are in terms of the actions and reporting requirements and the wide berth we have to not hold people. I think sometimes the assumption is very far in the direction of like, I'm going to be locked away if I'm even just having suicidal thoughts. And that should not be the case anymore. It requires a full suicide risk assessment. And if the person really is just not forthcoming about the suicidal thoughts specifically, I would use a whole host of other questions and probes to get at other suicide risk factors. Because remember, suicidal ideation, plan, and intent is an important part of the suicide risk assessment. Don't get me wrong, but it is not the whole of it. So you can ask them about things that get at their hopelessness, their prior history of attempts, do an assessment of where they are clinically, and if there are losses, rejection, experiences of humiliation, or other psychosocial changes going on in their life. All of those could lead you to believe that they actually are having an increase in their level of risk dynamically over in this moment in time. And then I think the important thing is obviously documenting this to try to document where your own assessment is landing with their level of risk and essentially why you're choosing the treatment course that you are.
Wow, that's so fascinating. Wow. Thank you for sharing that with us. The next question here is more of an example. This person states a scenario that could be going on with a depressed patient. And so they say the depressed patient says, we've tried everything over the past years, nothing helps. What is the point to go on to suffer more? If this were cancer, metastatic to the bone with unrelenting pain and no hope, would that be enough? What is your response to a patient who said something like this?
If a patient is really actually getting more specifically and concretely requesting physician aid in dying, that is obviously a whole complex topic that I'll keep actually separate and not really go there for the purpose of this, because in the field that I'm in with the suicide prevention science, it's so strong and so clear around the fact that suicide risk and that sense of hopelessness and desperation, and also the sense that their suffering has been forever and will last forevermore, is a distortion of the brain in that moment related to that culmination of suicide risk and the cognitive constriction, the tunnel vision that happens around that level of acuity. And so we actually see kind of physician aid in dying as a quite separate issue related to terminal illness. And so again, I will just speak to, for the patients who we're talking about, a very severe, maybe treatment refractory mental illness, I would ground yourself in the truth, because some of us, more than others, can be really almost contagiously influenced by their despair. And we have to not buy into that. We need to ground ourselves in the truth that they have been in a better place before, however long ago it was, and they therefore can get there again. And even in the case of the most treatment refractory mental illness, things can change. And being that reminder to them, holding on to that truth and that hope and expressing it to them. Say, I know that you're suffering right now, but remember that there are moments like this make that you feel that things will never change and that it's always been this way, but the brain can play tricks on all of us. And especially when you're in this state of your mental health. And I believe that you can get better. You can get back to a certain level of your healthier self. If you can ground yourself in that truth and that belief, then you have to tell them that, because that hope can actually be contagious to them. And just really, I was trained that, like the APA guidelines point out, remission is the goal of treatment, even for treatment refractory depression. And so you keep on. You don't just give up and be satisfied with a very minimal or partial response, or even if it's recurring. You keep on. You have to adjust the treatment, just like we would if we were a cardiologist treating more tricky, let's say, refractory hypertension and various other conditions. We have to ground ourselves in that research that shows that we can find things, and we do have new treatments that are providing those avenues for recovery. So it's really being a sort of relentless voice for truth and for continuously aiming for remission, and that there are other options available.
Wow, that is so inspirational. I love that. This next question, the person says, other than conducting a proper suicide assessment, are there any other things that should be documented accurately to avoid litigation for the provider? Any suggestions on effectively completing a comprehensive structured intake interview and suicide risk assessment within 50 to 60 minutes?
Yes, I know. Time is the challenge in an initial visit. And remember that while you should at least cover a brief suicide risk assessment in any initial visit, that by no means needs to be your complete, full, and comprehensive suicide risk assessment. And in fact, the best, what we call suicide preventive oriented suicide risk assessment or risk formulation happens over time. Obviously, if this is an outpatient of yours, theoretically, you're going to see them many, many times. And so your suicide risk formulation will continue to evolve over time. And you can almost keep a separate pocket of your brain that's focused on that and constantly filtering their changes in not just suicidal ideation plan and intent, method, access to means, but their history of attempt, their family history. New information sometimes comes out later in the treatment. What I would highly recommend is that there's an approach you take that's sort of like your standard approach, because it helps to have that be uniform, so that there's a universal screen that you're doing on every new patient, and if not at every visit, at key points in time in the patient's trajectory. There's an inventory that I really called Reasons for Living. It's been integrated into the CAMS treatment, the Collaborative Assessment and Management of Suicidality that David Jobs has. That Reasons for Living itself, the form itself and the instrument, will bring so many points of discussion to life that will help you understand their protective factors. And so it's doing this process. It's having 4 or 5 of those other risk factors besides suicidal ideation, a plan and intent, and doing that every time. And then over the course of time, making sure that you're digging deeper on those other risk factors that could relate to past trauma, that could relate to previous events, suicidal incidents in their life. And then obviously the key is documenting all of this. Now, what I would do is I would document not only those specific risk factors that are part of your suicide risk assessment, and not just your specific protective factors either, but document your interpretation and your rationale for what is happening. Putting things into place like a safety plan for a patient with any level of suicide risk is highly recommended and protective for the patient and protective for the clinician as well. And then lastly, making sure that addressing lethal means is happening. You can go there in the conversation with the patient, and if they are at any level of risk that's elevated for them or higher than low risk, then I would absolutely be talking to the patient. And I recommend at the outset, at the beginning of treatment, have them give permission for communication with a small cadre of people. Maybe it's a significant other. maybe it's their primary care doctor or provider, and maybe it's their co-therapist or psychiatrist if you're the therapist, so that you're telling them when there are moments in time when it's important, I will be able to give you the best care if you are allowing me to communicate with these individuals. And of course, that can be revised over time and they can specify that. But then having those conversations when risk is developing and documenting that conversation with the family member or with the primary care, because again, it will help the patient and it will protect you as well.
Wow, that was such an excellent answer. Thank you so much. This next question, the person says, is there any idea that lithium's anti-suicidal effects could be dose related? Can 150 milligrams have the effect or 10 milligrams of orotate?
Okay, this is a great question and not such an easy answer, because while we have literally more than 50 studies and covering huge swaths of numbers of patients, as well as ecological studies of like trace amounts of lithium in the drinking water in certain regions of the world, having a suicide protective effect. That data is very strong. What we don't know as well, the dose that is required for protection of suicide risk, and also perhaps depending on the primary psychopathology too. So for example, the way that I would approach this is I would first go by, okay, if I have a bipolar patient I'm thinking of lithium both because they're not fully mood stabilized and they are at higher risk for suicide, which by the way applies to almost every bipolar person, just because of the bipolar disorder. Then I'm thinking of lithium to target first and foremost their mood stabilization. And usually that does require lithium with blood levels in the actual therapeutic range of 0.8 to 1.1. But if I'm really not needing it for full mood stabilizer effect, so that's either the bipolar patient who is well mood stabilized, but you're thinking of for suicide risk, or it's the unipolar depressed patient you're thinking of augmentation with lithium. In those cases, I absolutely recommend starting with a longer period of low dose lithium and following them clinically to see what happens with their suicidal thoughts, with their impulsivity, with any of the factors that may fuel their suicide risk. Because there is some data to suggest that even at lower doses, 150 milligrams, 200 milligrams, 300 milligrams a day, that you can see changes in suicide risk even when it's not impacting the overall mood condition, which is a fascinating thing that's borne out in the suicide research literature as well, that shows that suicide risk, while it certainly is impacted by mood, do not get me wrong, but in many instances, there is a separateness that they can run sort of their own courses, especially when the suicide risk relates to other aspects of neurocognition, of impulsivity, of the cognitive factors that relate to suicide risk. So I am a fan of trying lower dose lithium in those instances that I mentioned when it's not being used as a full mood stabilizer.
Excellent. This next question states, if a patient on an antidepressant dies by suicide, can we turn to an expert psychiatrist or psychologist for expert support, even legal? And if so, how?
Yes, after a patient dies by suicide, there are actually a number of highly recommended steps to take, which I do cover in my recent clinical handbook with Steve Stahl. There is a chapter that's devoted to this. And one of them is to seek out a way to certainly take care of yourself in the aftermath, because it can be so impactful on a personal and professional level that it can be quite damaging to us as healthcare providers. But the other thing to keep in mind is that getting expert consultation, if you will, is always a good idea. Now, what I want to say is the most timely moment to do that is when you are realizing, oh my goodness, my patient's suicide risk is of concern. It's escalating, and I'm doing what I can. I would not even wait to feel that level of angst. I would be seeking out consultation from a colleague or from an expert. I would be documenting that, getting support for yourself, guidance, suggestions for other ideas. Sometimes it's hard to remain totally logical and rational in that moment when it is a very anxiety-provoking moment for the clinician as well. So there are really very important moments in time to seek expert consultation. So when risk is emerging and increasing, and also after a patient takes their life, that there are a number of things. I would first be contacting risk management. I do recommend allowing for meetings with the family when they request. That can be a very helpful thing and does not have to increase clinicians' medical legal risk. In fact, it can mitigate it. And yes, the short answer is yes, I would lean on trusted experts for support and consideration of potential legal issues there as well. Although I would primarily first and foremost be leaning on risk management for guidance around that.
Thank you. The next question is, what is your view on gatekeeper programs in the prevention of suicide other than mental health first aid?
Okay, great. So just in case anyone isn't familiar with that term, gatekeeper programs are education programs for key people in specific roles like teachers, law enforcement, people who deal with the public and deal with their day-to-day jobs, have them interacting with members of the population who may become at risk for suicide. And what I would say is for many years, gatekeeper trainings, programs, and there are many, were being developed, but the evaluation of them was slower to come. Well, even before we had the evaluation data, which we do have more of now, I'm happy to say, they are, I would consider them step one in any public health approach, where you have to provide a language and a level of education and knowledge to the whole population. And in the case of gatekeeper training, really to those key individuals who play a frontline role in dealing with at-risk people and may be able to facilitate a referral to the health system and to mental health treatment. So having a reasonably educated population is like step one of a public health approach. And then you need to educate those special individuals a bit more. So it makes all the sense in the world. And now we do have evaluation data from a number of those programs. And I'll just highlight two quick things. There is an evaluation that was done of all the counties in the United States that received Garrett Lee Smith grant funding. Now, the Garrett Lee Smith Act provides grants from the government to counties and tribal communities to put on suicide prevention activities, gatekeeper trainings, a whole range of activities. And what that study showed is that the counties that received that funding and put on those programs, including gatekeeper trainings, over a period of 3 to 5 years or more, showed reduction in suicide rates of those youth in those counties compared with the control counties that did not receive the funding. So that's a very important, very promising study. And I'll just highlight one of AFSP's programs, which teaches teachers and any school-based staff in K-12 settings how to recognize distress as possible indicators of mental health deterioration and suicide risk, and how to get their policies and protocols in the school and have their mental health resources ready to go, and how to engage students in that process and how to keep parents informed. That program, called More Than SAD Educator Training, has just undergone its own independent research study showing that the impact on those teachers who received the More Than SAD training had not only differences in their knowledge, attitudes, and confidence, but their actual behavior of engaging with high-risk students and making referrals. And so it's hard to show behavior change from programs, but there is reason to believe that many of them can and do that. What I would say is gatekeeper training programs are not enough, and it can't be a one and done. There needs to be a more comprehensive approach to really impact suicide risk for a population.
Wow, but that's such great news about these programs. But wow, that is so powerful, I think. And it's an excellent start.
Yes.
The next question says, many patients do not want anything that will potentially increase weight, such as lithium. I have to tell patients risks, and this is one that frequently results in medication refusals that could help mood and reduce suicidality. What are your thoughts on this?
It is probably one of the toughest concerns about lithium, in addition to the other issues that we need to monitor for related to thyroid and kidney over time. But the weight gain and the sort of cognitive slowing or that cognitive dulling, I think they're two different things. First of all, weight gain is more common. It is possibly, we're not sure about this, but it is possibly more common when lithium doses are higher. So it could be a dose related effect. Again, the data is weak on that, but there are those of us who hope that the little bit that we have is pointing in that direction. So what I would do is, again, for unipolar depressed patients who are at risk of suicide, I am a big proponent of trying low dose lithium in that population. And I would explain to them that you will work with them, that if there are any concerns that occur that matter to them, that you will be amenable to either stopping the treatment, trying something else. And also it's important to know that if a patient is sensitive to lithium-induced weight gain, you'll see that weight gain in the first few months of treatment. It is thought to not just continue on forevermore as well or more. It's thought to plateau and diminish at about the 1 year mark. And lastly, if the benefit is clearly outweighing the risk and that adverse effect, there are ways to mitigate weight gain, obviously, some of the basic ones that we all know. There are also case reports of using metformin to effectively reduce weight in patients on lithium. So that's another idea.
Excellent. So this takes us to the last question, which is, what tools and basic education strategies can we use for non-healthcare professionals to highlight and prevent potential suicide or suicidal thoughts, as often suicidal thoughts can be related to burnout in people with no underlying risk?
Okay, so if I'm understanding this question, I'm hearing this about how do we help people outside of the clinical setting? In other words, are there things that we can do to provide support and mitigate risk out there in the community setting? And there's also this part of the question that's about suicidal thoughts really being either related to burnout or just not necessarily having to do with mental illness. And what I'll say about that last part is that suicidal thoughts are so common in the general population. It's hard to pin that down exactly, but the studies show that in a discrete moment in time, anywhere from 5%, depending on the age, older adults, it's in a lower percent like that, all the way up to during COVID, it's been 25%, 1 in 4 young adults reporting serious thoughts of suicide in the last 30 days. Suicidal thoughts are not necessarily just stemming from mental illness. That is absolutely true. Remember, suicidal thinking is the brain's attempt to try to problem solve their situation that they're in. So it might be a fleeting thought among many where they're sorting through, how am I going to get through this painful thing that I'm going through? However, moving from suicidal thoughts into action is an indicator that really expresses to you, the clinician, that they are in a different category of risk, because the vast majority of people who think about suicide do not move into planning or acting on that. So almost by definition, I'm thinking a much higher risk category once a person has attempted. Whereas suicidal thoughts, again, now it depends. Some people who have very significant persistent chronic thoughts of suicide, that is almost its own phenomenon that it can almost be a form of coping and a comfort to the patient. And so you have to be careful with that one, because you need to try to keep the alignment with the patient therapeutically, but also be thinking about where they sit and why they're having those suicidal thoughts, so you don't alienate yourself and they're just then rejecting everything that you're advising.
Right.
But that topic aside of like suicidal thoughts being of concern, but not necessarily indicative of mental illness, there are so many things that we can do on an individual level within our families, within our communities, neighborhoods, school settings, faith organizations, as well as things that our community leaders and policymakers need to be doing and that we all can be advocating for. And so there's kind of layers to suicide prevention out in the community. And what I'll say to just boil it down is that we've already talked about gatekeeper training and educational campaigns and programs that are all important in laying that foundational part of the public health model for preventing suicide, because we need to destigmatize, we need to have common language, and people need to be able to talk about their internal experiences, because that's the layer that we're missing so much in reducing suicide deaths in the United States, is that there are more than half of young people who die by suicide, for example, have not ever disclosed that they were having suicidal thoughts. And so there's the basis for being able to take stigma out and give people the ability to dialogue. But far beyond that, we do need much more. We need to equip all of those parents, teachers, law enforcement, people in key roles to have a level of sophistication so they are not inadvertently driving suicide risk underground or even raising risk by the way that they're handling different scenarios. And that's a huge movement right now with 988 launching in the summer of 22, that we will have right now. We have the opportunity to educate and create new systems and pathways so that we're not running into experiences of assumptions, discrimination, and it really does link up with the race and health equity topic.
Right.
But there are also things that we can be doing, again, as policy leaders at the local, state, or federal level that would be impacting suicide risk for good for the whole population. And those are things like making sure that there's parity for mental health treatment compared to physical health, access to care, things like mandating some of these educational efforts for teachers, for example. Most states have passed those laws now that require that level of engagement. And lethal means is another big piece to this. When somebody is in a suicidal crisis or a period of time when they're struggling with their mental health and they're suicidal, it is really imperative to make sure that their environment is cleared from lethal means and that those lethal means are secured. Because beyond even just saving a life, because in that moment of acute risk, if a lethal means is not easily available, lots of data shows that they move on. They live past that acute moment and they don't just switch to a different method that may be more available. But that there's even something about the availability, the visibility of those lethal means that can increase suicide risk, that can draw the person into to those urges. And so I can't emphasize that enough as people, any listeners, both in terms of when you're doing your patient care and educating the patient, involving family, but also in your personal roles in your family life and in your community to be, this is the most practical thing we can do related to suicide prevention, is making the environment that all lethal means are universally always secured, but particularly when you know someone is struggling, to have extra sensitivity and care to make the environment feel and actually be safe to that individual. And it's not something that we have to do without their consent or in an adversarial way. Sometimes, of course, it does get to that point, but there is so much room for engaging the person. Remember that ambivalence. There is a part of the suicidal person's mind that wants to stay alive and can be influenced to take that step and anchor deeper into safety and their future. And those are the things that we can do in treatment, but those are the things we can also do as family members.
Absolutely. I love
Wow. Every time that we interview you, you just bring so much incredible, valuable information to such an important, crucial topic. And I just want to thank you so much. I think it's important to keep in mind that our listeners will be clinicians, but may not be clinicians. And so it's so important to me that you've shared just so many resources for everyone out there and that we can all try to do our part. This has been an incredible interview once again.
Thank you so much, Sabrina, for having me on and most importantly, for honing in on suicide preventive actions that clinicians and general citizens can take. I think this is such an important topic right now, and I'm just so grateful that you and your team at NEI are taking the time to highlight it.
Thank you. Thank you so much.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.